Good morning and welcome to the Weekend Wellness Hour show. This morning I have a guest on who's also a friend of mine, Dr. Lee Newton, who's an optometrist in the Michigan state, and he's been an optometrist for 20 years. Lee and I, Dr. Newton and I, met last year. We're both in a mastermind for entrepreneurs who are looking to grow and expand our knowledge in the business world and just providing value to other people. And Lee also has a background in real estate investing, and so we've kind of connected on that level as well. So I want to wish Dr. Newton welcome. Thank you for joining us today.
Hey, Amy, my pleasure to be here, and Lee works just fine.
Okay, going back and forth, it's a little bit confusing sometimes, going back and forth.
Just fine.
Thank you very much. So why don't you tell us a little bit about how you got into caring about the eyes and going into optometry?
I was a kid, and somehow I got interested in eyes. And first, I was interested in music, and I still play music. I played saxophone for, over 30 years, and I explored my career options with music. And saxophone wasn't a main staple of a symphony orchestra. So I didn't really see a career playing saxophone. So then I thought, well, I guess maybe I could teach music, but that just really wasn't my passion. And my interests and passions kind of shifted towards science and healthcare. And I had always had a need for visual correction, so I was no stranger to the optometrist's office, and learned a little bit more about this profession over time and realized that, hey, this is something that I think I might like to do. And it was a decision I ultimately made at some point early to mid high school, and I just stuck with it and went to undergrad and then grad school, and then 20 years later, here I am.
That's wonderful. Now you have your own practice now, correct?
Yes, and I always have.
Okay, you always have. So you jumped right from school into your own practice, and I imagine that gives you some independence and autonomy to treat the way you'd like to.
It does, yes, because I don't have anybody telling me about a certain quota or a certain lens that they want prescribed or a certain treatment that they want prescribed because somebody else told them that they have a quota. So I can,
Yeah.
Rigorously independent. I can do exactly what is in every patient's best interest.
And that's fascinating. I totally understand that. And so what is one of your passions regarding eye care? Do you have a patient population that you really enjoy?
Over time, I've come to really like and appreciate the opportunity to help kids that have problems that lenses won't fix.
Okay.
The old analogy is, I mean, if you can sit there and read the 20/20 line of letters, you think, okay, I'm fine and my eyes are fine, my visual system is functioning appropriately, but
Mhm.
that doesn't tell you anything about visual function. So a lot of these kids, especially in this day and age where there's virtual education and we're looking at screens for many hours a day. I mean, if you take somebody that stares at a screen for his or her job 8 hours a day, that's close to half their waking hours, and that can cause symptoms. And then you take a kid that doesn't really know how their eyes are supposed to work. They just know that they're having to exert a lot more effort to do what other kids are able to do a lot more quickly and easily than them.
Mhm. So when you're working with kids, so if lens can't correct their problems, what are some of the things that you do with a child when it comes in and it's having trouble?
Mhm. And there are many different types of ways they can have trouble. One way is their eyes simply don't want to maintain focus or change focus from distance to near, back and forth fluidly or easily. Other kids have a difficulty with smooth and efficient tracking across a line of text and then the return sweep. Still, other kids have trouble with converging their eyes. We actually have to point our eyes at what we're looking at. And if we're looking at something far away, then they need to be parallel like this. But if we're looking at something like a computer screen or a book, they need to not only converge, but hold it there. So lenses won't fix problems in those areas, but we do vision therapy, which is essentially retraining the brain and the visual system how to control the eyes and not only how to process information, but how to function more efficiently.
Which obviously is critical for reading skills, comprehension, all of that, I imagine, for
Yes.
school and progressing. Yeah. So when you're doing these treatments with the kids, is it using your eye muscles, like retraining the eye muscles, and they're focusing on something to learn how to use the various muscles around the eye?
Kind of, kind of.
Okay.
If a kid or the person in general, if they have an eye turn, let's say,
Hmm.
it's commonplace to assume that they have a weak or lazy eye muscle.
Yeah.
Now, there are 6 muscles around each eye. We can't see them because they're covered by lids and other tissues, but they're called extraocular muscles.
Hmm.
Those muscles, fiber for fiber, are the strongest muscles in our body. So there's no weakness of any muscle ever. It's simply either a control system problem.
Hmm.
Sometimes kids have problems that lenses or vision therapy neither will fix, and some kids actually do need a surgical adjustment to the insertion of a muscle because it might be overacting, for example, and
Hmm.
that is rare, but it does happen. So
Okay.
it's not necessarily training the muscles, it's actually training the brain to control the eyes a little bit more efficiently.
Okay. That makes sense. And I'm glad that you're able to actually make a difference by retraining the nervous system and that neuromuscular control. I mean, that's powerful. So do you see similar problems in adults, or do adults kind of come out of that stage, or is it because they don't have as many of those problems because they've gotten the trainings from people like you?
That's a great question. And we definitely have more kids that we've treated with vision therapy than adults. We have
Hmm.
treated a handful of adults with vision therapy. And I think that the answer to the question is somewhere along the line between childhood and adulthood, it was picked up, or that individual simply learned to compensate in other ways. I have
Hmm.
seen adults that have convergence insufficiency. And what that means is they can't converge their eyes any closer than, let's say, a couple feet, but they
Okay.
simply have adapted by adjusting their working distance. And so I hold something here and it's double, and I'm thinking to myself, doesn't that bother you? But then we have to sit back and say, well, gee, how are they functioning in their world, their environment? If they're asymptomatic and if they're happy, then I guess there's not a problem and it's not broken.
Yeah. Yeah. And why mess with it, right?
Correct.
So, what are some of the most common problems you see in kids? Is it the tracking or is it another condition?
It's the tracking and eye movement control,
Okay.
the top two.
Okay.
Focusing, to some extent. Some focusing challenges can be dealt with lenses, and that's if a lens will ameliorate the symptoms, and that's easier and quicker than 12 to 16 or more weeks of vision therapy, and then by all means, let's prescribe a lens.
Yeah. So do we know why these kids are having the tracking problems? Is it genetics or environmental factors, or do we know?
We really don't know. I mean, there's a certain
Yeah.
incidence of kids that have tracking problems, and there always has been, and
Hmm.
that's just the way it always will be, probably.
Okay. Okay. I was just curious. And what about some of the common things that you see in adults?
Adults in terms of like tracking or anything like that.
Like kind of the most common eye issue that you see in adults, just generally.
Lately it's
Sure.
been, I mean, there are medical conditions that we deal with, but in terms of vision, it's a vision complaint that has its origin in our current work environment. Someone might have good vision for distance, and they might be at the point where they need reading glasses to see something this close to them, like reading a book. But then again, a computer is maybe 2, 3 feet away. So they think, well, they can see the screen and the text on the screen clearly. But what
Hmm.
happens is trying to sustain that focus over a period of time, it does induce quite a bit of fatigue. And then those reading glasses that are good for here, they're really quite strong for something that's out here in the 3 foot space. And then
Okay.
you add into that equation the nature of the text on a computer screen. It's pixelated. And even with our
Yeah.
high resolution monitors these days, the resolution or the contrast it can approach, but never really rival 100% contrast, presumably of printed text on a page, where there's the junction between a black letter on a white page. There's
Hmm.
text and then there's no text. Well, a computer screen, if you get really close to look at it, it's kind of a fuzzy edge. And that tires our focusing system out quite a bit.
Oh, really? So for people that are in front of a computer all day, do you recommend only look at the screen for 15 minutes and look away and move your eyes around, or how do you even adjust for that?
Yeah, there's a cheesy variant of that. It's called the 20-20-20 rule. And what it
Okay.
says is that every 20 minutes, look at something 20 feet or more away for 20 seconds. So if
Okay.
you do that and you transition your gaze from a computer screen to like out the window and you're looking at a billboard across the road,
Yeah.
and it takes 5 seconds for the letters and the text to become clear, that's how long it takes for your eyes to actually relax from this engagement of focus to something that's 100 yards away.
Yeah.
So 3 times an hour for about 20 seconds.
Okay. And that makes sense. I mean, now with COVID and a lot of people behind a screen even more, and even kids behind a screen for 6 hours a day of lessons versus when they were in the classroom, bet that's even more important now.
Indeed.
Yeah. So that's impressive. Now, I like that rule because it's very simple and easy to implement. So, do you also see a lot of changes in the eye regarding diabetes? Because we know that's more important nowadays.
Well, when I graduated from optometry school, 2000, at that time, diabetes was the leading cause of newly diagnosed blindness. 20 years later, it still is. Now, a lot of that statistic, I feel, and I can't prove this, I don't know it for sure, but I feel that in a lot of areas of the world where people maybe don't have the access to care that we do in this country might contribute to that statistic. I really
Okay.
don't like saying that statistic because it tends to scare people, but
Mhm.
diabetes can cause leaky blood vessels in the eye and swelling in the back of the eye, the retina. And if that gets to a certain point, then it starts to deteriorate vision. If it gets to a certain point, before that, we can make a call and make a referral to a surgeon that can do either a laser treatment or more commonly these days, actually an injection, anti-inflammatory, to keep that swelling at bay and preserve vision loss before it occurs.
So, so when you're doing a regular eye exam, is that the marker, the swelling that you see, or a leaky blood vessel that you see to really bring someone's attention to the diabetic issue?
Yes, if there's a patient that's a known diabetic and their blood sugar is generally under good control, and if we
Mhm.
see 1 or 2 small hemorrhages in the retinal periphery way out in the back of the eye, we're not that concerned, and it probably wouldn't even change the re-examine protocol from 1 year to sooner. But if we see
Okay.
more of them, we might say, well, probably need to look at that in 4 to 6 months to make sure it's not accelerating. If we have someone that's not a known diabetic and they're in for a regular eye exam and to make sure that they're healthy and we see a random hemorrhage, chances are they are diabetic. I mean, it's the
Yeah.
most common condition that causes an idiopathic or unknown hemorrhage. Like, where did that come from? So we would
Okay.
make a referral to their primary care physician to complete a eval and a blood work and so forth.
Yeah. So do you also give diet advice to diabetics and just say, hey, because you have excess sugar and it's poor regulation, this can get worse. These are some common things to not eat or anything?
Yeah, I probably don't give, and maybe I should. I try not
Yeah.
to get too detail with the diet advice. Generally,
Yeah.
the patients that I have good access to is probably they just need to be reminded. I'm
Yeah.
probably more apt to remind them, hey, you got to be a little more diligent with your blood sugar control because, and this
Yeah.
was an example a few weeks ago. This gentleman was in his early 50s, and I had to make a referral for an injection, and a year and a half later, I think I had seen him early 2019 and then mid
Hmm.
2020 or fall of 2020. His one eye was kind of mild to moderate, didn't need any treatment. The other eye was to that point, and then the first eye had some swelling, and he was like 20, 30, 20, 40. So he's going to be on the injection circuit once a month for probably 3 to 6 months to get stabilized. Now, if that
Wow.
patient doesn't make significant lifestyle changes, then he's
Hmm.
going to end up with very, very poor vision in one or both eyes in the future.
Okay. Okay. So now, if someone, now I don't even know if there's statistics on this, if someone starts to change their diet right away, get their blood sugar under control, do you see within a couple months the swelling go down, things start to heal? Is it that fast of a change? Do you know?
When you get to a certain point that gets, it's called clinically significant macular edema, they need medical
Mhm.
slash surgical treatment to get it down. But if they do
Okay.
make those modifications, it can stay corrected. It can stay at bay.
Okay.
The thought came to mind a moment ago. One time I had a lady that her blood sugar was not under control, and she had I couldn't help but see in her purse, she had like a 1 liter Mountain Dew. And I couldn't help but mention, like, that's not, you have these eye problems and that's not helping you. It's just not
Yeah.
helping you. And the response kind of killed me because she said, well, sometimes I mix it with diet. I'm like, oh, it's probably even worse because the artificial sweeteners and all that. And I'm not a dietitian, I'm not a
Yeah.
nutritionist, but I don't know how well I made that point with that patient.
Yeah. Yeah. And sometimes they have to be ready to want to change.
Yeah.
And so sometimes it requires something severe to get a change. So unfortunately, but that's fascinating. Now, are there any other things you see with diet that affect your eyes? Like we always hear about carrots, beta carotene, that improving eyesight is. Are there other things?
There are no like light bulbs that go off. So you need to
Mm-hmm.
take this, you need to eat this or that. But
Yeah.
generally, what's good for your body is good for your eyes. Studies have shown an association between poor diet and
Mm-hmm.
macular degeneration. So it
Okay.
might start early, it might be more severe. I had a patient last week, and she was about she was within a year of my age, mid 40s, and
Mm-hmm.
she had the start of a cataract, and she was an alcoholic. She was having trouble with alcoholism, and so I thought that was interesting. The cataracts weren't severe, but in 10 years, she's going to get them a little earlier than average.
Yeah.
So what's good for your body is good for your eyes. So I often get asked about supplements. Hey, should I take this eye vitamin? Okay,
Mm-hmm.
and typically the question is framed like, should I take this vitamin so I won't get macular degeneration? And I have to say, hey, we don't have that information because there was
Yeah.
a great eye disease study, the AREDS, age-related eye disease study, and then a follow-up. And the conclusions were that a certain formulation of nutraceutical, okay, will reduce the risk of progression. Well, progression means you have to have something to begin with. So
That's true.
the patient, if they already have mild to moderate macular degeneration, taking an AREDS formula will reduce the risk of progression by 25%. We
Okay.
don't have data that show if you have healthy eyes, you take this and it'll reduce your risk of getting it. So we just can't say
Right.
that. Now, studies like that are probably in the works right now. So if you have
Gotcha.
macular degeneration and it's more than just a little bit of aging change, then I do prescribe and recommend an AREDS supplement. There are other nutraceutical supplements that are supposed to help dry eye and other things. And I don't know to the extent that they do, but there are other treatments that I usually try first.
Okay. So that's good to know. What about dry eyes? Can you talk to us a little bit about that, some of the causes, if there are some, and what you do about them?
In my opinion, dry eye is the most prevalent and underdiagnosed eye condition.
Okay.
And dry eye can make contact lens wear more challenging. Dry eye can drive someone into my office and says, gee, I need a new prescription because I can't see clearly. And their eyes are dry and we can't get a good prescription endpoint. And I say, hey, let's do this. Let's treat the dry eye, let the dust settle for 6 weeks. You probably won't even need new glasses when they come back. Oh, gee, I can see a lot better. Hey, problem solved.
Yeah.
So dry eye, I mean, our eyes produce less tears as we age, so the tear
Mm-hmm.
production goes down. There can be a tear quality issue because there are 3 layers to our tears, and the consistency of those layers is very important. Medications can reduce tear production. I mean, if a medication if a systemic medication has an ocular side effect, 9 times out of 10 or more, it's decreasing tear production. And so dry eye is the most common and prevalent and underdiagnosed condition. We talk about patients that have sleep apnea and CPAP machines, and you have excess or random airflow currents that can dry out the eyes while they sleep. So dry eye is connected to a lot of symptoms.
Okay. So then is the treatment eye drops?
Usually, yeah. I mean,
Okay.
we want to look at a lot of different things, and it depends on the severity. But if a patient can be made asymptomatic by a daily, 1 or 2 times a day dosing of a good artificial tear, everybody's happy because it's a low level, it's easy, it's an inexpensive treatment. Some patients need a prescription drop for dry eye, and there are two or more that are available. One is advertised pretty much, it's called Restasis.
Oh, yep.
Actually helps you make more tears, and it helps you make better quality tears. And there are a couple other prescription drops. We can also put little plugs where the tears drain. So about 80% of the tears drain and about 20% evaporate, more or less. And the drainage areas of our tears are nasally. So there are lower and upper drainage areas that the tears drain in. So we can put little, and I refer to them not as a plug, is what they're called really, but I also refer to them as kind of like a foam stopper in a bathtub. It kind of lets some of the water through, but not all of it. You know, we don't want to take a dry situation and make a watery situation, because that can be annoying.
Yeah.
You know, and that's not, I don't use that as first line treatment on everybody, because if the tears are inflammatory in nature, if we need to do other things first, it's kind of like putting a stopper in an inflammatory swamp of tears on the eye, you know.
Yeah.
And then there's more inflammation, and it's kind of like a vicious cycle. And we need to look at other things like how much water are you drinking per day versus, you know, coffee and carbonated beverages and that sort of thing. What is the humidity in your indoor environment like? You need to maybe use a humidifier at night while you sleep, so forth. So lots of different things we can do.
That's nice that the surgery option is kind of on the back burner, that there are a lot of ways that you can enhance the moisture in your eyes. That's great to hear. So do the plugs, are they once a lifetime if you have to have those plugs?
No, they're all temporary. And it's not a, you know, it's a surgical procedure code, but it's not surgery, because we're not cutting on or changing the tissue at all. We're simply inserting a little plug. And I really like to use a variety that is made of collagen, and it dissolves in 90 days, approximately 90 days. So let's take, you know, in the middle of the winter and it's dry and the patient's eyes are dry and drops aren't working. And hey, let's try these plugs, because if you don't like them, they'll be gone on their own anyway. And it's an easy fix to the problem. You know, if it works, it works. And if it really does work, the patient's asymptomatic, and then about 3 months later, I get a call, you know, hey, my eyes are dry again. Well, that means they worked. Or we can either do another round of that, or we could put the permanent ones in, which they don't solve, but they don't last forever either.
Yeah. Oh, that's good. So it gives you some options. That's great. So what about floaters? Can you talk to us about floaters?
Yeah. Everybody's going to get them at some point. And
I know.
they can be very annoying.
Yeah.
So if we talk about the eye structurally, let's conceptualize. Maybe if I had a model, it would be easier, but let's just kind of picture an eye cross section, and the front part of the eye, the clear front part, is the cornea. Then behind the cornea, you have some clear fluid. It's called the aqueous. Then you have the colored part, which is the iris. Behind the iris, you have more aqueous, clear fluid. Then you have the lens inside the eye that doesn't want to focus anymore, and that's why we need reading glasses in our 40s. But you're still only about a quarter or a third of the way back from the front to the back at the lens. So from behind the lens all the way to the back of the eye, there's this optically empty space that's filled with gel called the vitreous humor. So it's a clear gel, and it takes up 2/3 of the volume of the eye, 3/4 maybe. And over time, that gel liquefies. So it changes form a little bit from a gel to a liquid, and it kind of pulls itself away from the retina. So it hopefully leaves the retina intact. But every once in a while, the vitreous pulls away from the retina and pulls a chunk of the retina off with it. So that would be a retinal hole or tear, and that would need to be treated surgically to essentially weld the tissue together so it couldn't detach. That would be a big problem.
Yeah.
When the vitreous is in the process of detaching itself from the rest of the eye, the piece of it breaks off and it floats around, and you see a shadow of it, and that's the floater.
Fascinating. Okay, that's interesting, because I just noticed not too long ago I have one in one of my eyes. It's the same shape, and it just kind of is there. And so I don't notice it during the daytime. It's only when I wake up, and that's what I hear from other people as well. So for the most part, there's not really much you do about them. Is that correct?
That's correct. If you have a new floater, you definitely want to be examined to make sure that your retina is intact all the way around 360 degrees.
Okay.
And then you can, sleep better. And The doctor will reassure you that over time you'll notice it less. Can't make it go away, but you'll notice it less.
Yeah. Okay. So good information to know. So now with macular degeneration, there's a lot of information out there about that. People, you typically hear it towards the end, later years in life. Are there things to look out for with it?
Well, if we go all the way back to our childhood years, we need to stress sun protection, solar protection more than we do.
Okay.
There was a statistic that I've heard from different sources, so it's probably at least mostly true, that most of our UV light exposure occurs between birth and 18 years of age. So sun protection during those years is way more important than it's being given credit for.
Okay.
So sun protection, the UV light from the sun can contribute to cataract formation and also macular degeneration. And so, yeah, we can treat cataracts to get bad enough, we can have them surgically removed. I mean, if you don't ever have to have a surgery, that's great. But statistically, if you look at the average life expectancy in this era, that most people are going to need to have at least one, probably both eyes operated on with cataract surgery. That's just the law of averages. Yeah. But you really don't want to get macular degeneration, because the only medical surgical treatment for it is when it gets to the severe wet type. So there are leaky blood vessels in the back of the eye that have burst through the retina and wreaking havoc. And if you have wet, then you need an injection to stop those blood vessels from growing. But by that time, your vision generally isn't stellar anyway, so you really don't want to get to that point if you can help it. So diet, solar protection, not smoking, those are things that we have control over. And having your eyes looked at periodically is something that you also have control over. And that's a good idea.
Right. So, I mean, that's great. I know my dad is going through the macular degeneration. I believe he's at the wet stage, and they've done injections and all of that. And so very familiar with how much it impacts your life and how much it impacts your activities, your confidence, your feeling of safety. It can really be detrimental to just your participation in everything.
And I think to someone that hasn't ever, and you're seeing it firsthand in your dad and someone else, it's hard to appreciate what someone might go through. And I think a good analogy is, ever since I've had to wear a mask to work all day, every day, like I can't see down, right? And so I'm running into doors and I'm like clumsier because this chunk of my visual space that used to be there and now it's not. And similar to macular degeneration, unfortunately with that, the chunk is kind of right in the center.
Yeah. Yeah. And that's, you imagine like how hard that would be that you only see the periphery. That's mind-boggling. So then how about, let's touch on glaucoma a little bit. Do you mind going through that?
I'd love to.
Okay.
Glaucoma is called the silent thief of sight because in its earlier stages, even mild to moderate stages, you don't know you have it. You can see clearly. Your eye's not red, painful. You have no idea what's going on. It starts by taking away vision in the periphery. So your peripheral vision, now if we take one eye at a time, if I'm looking at a point straight ahead, generally speaking, I have about 60 degrees nasal, 70 to 90 degrees temporal, 70 to 90 degrees down, and maybe 70 to 90 degrees up. And I might be 100 temporal, but generally speaking, we have this visual space that, guess what? The other eye overlaps. So I can see something in my left field of vision from my right eye, just not as far as my left eye can get, right? So there is some redundancy in our visual space, in our visual field. So if we lose some of that, we don't even know. We have a blind spot anyway that corresponds to where our optic nerve is, but it's covered by the other eye, so we don't know. So glaucoma, what it is the deterioration of the optic nerve because the optic nerve can't tolerate the pressure that it's subject to. The intraocular pressure is essentially defined as the fluid pressure of the eye itself over and above atmospheric pressure. So in other words, if you close your eyes and you press on your eye through your lid, it presses back with a certain force. It's not like jelly and it's not like a marble, hopefully.
Right.
And so we measure that pressure in millimeters of mercury. And a normal range is roughly 12 to 22. 24 isn't necessarily, 22, 24 is just kind of, that's roughly the same number. Some patients can get glaucoma at 18 pressure, okay? That's called low tension glaucoma. Some patients can tolerate a pressure of 26 and never get glaucoma. So the ability of a patient's optic nerve to tolerate whatever pressure, it's totally individual and unique to that patient. So when the optic nerve decides that, gee, I don't like the pressure that I am subject to, it starts to deteriorate. The optic nerve in the eye is where all the individual nerves come together. And so it's a structure that's about 1.5 millimeters in diameter, but it contains over 1 million individual nerve fibers. So yeah, there's a lot of redundancy.
Yeah.
1 million. And that's why if somebody ever asks the question, well, how come we can't just do an eye transplant? Well, I don't know anybody that could suture 1.2 million nerve fibers in a 1 millimeter space. That's just not, it's one of the wonders of our visual system, in my opinion. And so those nerve fibers start to die. We start to lose peripheral vision in a way that at first we have no idea that's happening, but it can be measured and it can be quantified here in the office. And that's why if somebody asks me, I'm not having any problems, I can see well, give me one reason I should have my eyes examined, because I have never in my life, and I'm 40 years old, or it's been 5 years and I'm still doing okay. You got to make sure you don't have glaucoma, because you can have it and not know it. And generally speaking, about 1 out of 300 people are going to get glaucoma.
Yeah. Wow. That's incredible. That's truly fascinating. So when you see evidence of this, again, how do we reduce the intraocular pressure? Is there anything we can do overtly in our daily lives?
Well, there are some studies and these were probably 15, 20 years ago, so I should really look and see if there are some studies. But generally speaking, we want to put a patient on a topical eye drop medication daily to reduce pressure. Excuse me. And the eye drop will either help the patient produce less fluid, okay, or have the fluid drain a little bit better. So glaucoma is essentially a plumbing problem, right? We want to turn off the spigot, and we want to increase the drain somehow to reduce the measured intraocular pressure. But one of the studies I was thinking of, and I think this is way back to our graduate school, the study said consistent daily exercise could do the job of 1 drop. Because we've got patients that are on 2 or 3 drops per day, and 1 drop is maybe evening only, another drop is twice a day, and then the third drop is 3 times a day. That gets a little bit excessive. But in this day and age, there are good surgical treatments and minimally invasive surgical treatments. Okay, so a laser treatment, for example, can probably do the job of that extra drop that the patient's not really anxious to go on. If you take a non-compliant patient where that, they say they're compliant, but the numbers just don't add up, and a minor laser surgical procedure can help everybody sleep a little bit better at night.
Yeah.
But there's no supplements. There's no way other than just caring for your overall health, to make glaucoma go away. There's no cure for it. We can only manage it.
Right. And that's interesting about the exercise. We hear so much about just movement in general, gets fluids in and out of places. Here's one more evidence, or one more, study that says maybe there's a relationship to helping you out with the pressure. That's incredible. So do you see tumors in the eye? Is that a common thing?
Thankfully, it's not a common thing. And in my career, I have never seen an actual eye tumor, but a handful of times, an eye tumor typically called either a choroidal melanoma that's in the back of the eye, or there can be a basal cell carcinoma, squamous cell carcinoma, front part of the eye. But a handful of times I have seen signs that have pointed to the need for imaging, such as MRI. Like the optic nerve is swollen, we've got to do some imaging here, because you can't, I can see the inside back of the eye, but not the back of the eye, right? I don't know what's going on in the brain behind the eye. And those have been signs of a brain tumor. Okay, so the eye has a very, very unique thing about the eye. Fun fact here: it's the only place in the body where we can look in and see brain tissue, the optic nerve. connected right to the brain without doing some sort of surgery. It's the only place in the body we can look in and see vascular tissue, the blood vessels, without doing some sort of surgery.
Yeah. And that's fascinating because I had heard that about, looking in the eyes to determine other health conditions like diabetes. And I'd wondered about with the brain tumors, the possibility or at least an indication further studies are needed. So it's good to know. So would you recommend, like, let's say there are a lot of people who have an optometrist they see yearly. For those who don't see someone yearly because their vision's pretty good, do you still recommend that they see an optometrist yearly or every couple of years just in case?
I'm pretty conservative, and I'm not really totally on the everybody needs a yearly eye exam bandwagon. And I'm not saying that that's wrong. I have colleagues that disagree with me. People, in my opinion, that need to be seen yearly are patients that wear contact lenses most of the time. If they wear a daily disposable contact lens 3 times a month, then they can be a 1.5 or 2 year person. That's fine.
Okay.
Diabetics and systemic conditions that can affect the eye, those patients all need to be seen yearly. Patients with good eye health, good systemic health, not a real robust eye history in the family, and no vision problems, to me, that's a 2-year patient.
Okay. Okay. So now when you're talking about lenses and kind of getting adjustments, new lenses every 1.5 years or every year, is that kind of a standard change in people's vision? Or do some people just their vision changes faster based on a medical condition or their health? How does vision change over time?
That's a great question. Probably it's most efficient to start younger with kids. The myopia epidemic, okay, I don't know if you've heard that term, but myopia means nearsightedness, and I can't see things far away. I'm myopic, I'm nearsighted.
Yeah.
It's a real thing. It's not an infectious disease, thank God, okay?
Yeah.
But it is a real thing, and we don't know all the causative factors. We don't know to what extent it might be genetically transmitted, if it's got a gene pattern or whatnot. But we know that kids that get 1 to 2 hours of outdoor time, playtime most days, their risk of myopic progression goes down quite a bit. So another way that we just need to look at our overall health, right? Yeah. So, but kids that are myopic in the teenage or tween age years, they can have big prescription changes in short intervals of time. And we have better treatments for that now than we had when I was younger. We have ways that we can actually slow it down and control that a little bit better. The very, very dilute daily application of a dilating drop, atropine, can actually slow down the progression. We usually get 1 year or 2 of slowdown out of that. But corneal reshaping or orthokeratology, and that involves a therapeutic contact lens that's, believe it or not, worn at night while you sleep, and then it reshapes the eye, okay? So the beauty of that is, get up in the morning and they remove their retainers, the kids do, and they can see all day with no glasses, no contact lenses. But then the next night they have to put their retainers back in. So kids love that, parents love it, because parents now, they're not looking at, now I need to buy sports glasses, dress glasses. Oh, now they want contact lenses. No, let's just do corneal reshaping. They wear them at night, take them out in the morning. It's safe, it's healthy. And here's why I like it, is because that is proven to be the number one way to slow the progression of the nearsightedness. Okay, it's not a guarantee, but it's the number one way that we can slow it down quite a bit, and studies prove that. So those are great treatments, but there are other areas, other stages of life where our prescription can change a little bit. So like if we're in our 40s, we're going to need some reading glasses, and if somebody asks me, I mean, the store-bought reading glasses, that if they work, right? If they ameliorate your symptoms and you're happy with them, great. If it prevents you from getting your eyes examined and we missed glaucoma because you didn't come in, hey, that's not great, right? Right. Generally speaking, if computer is 2 or 3 feet away, a 1 or a 125 reading glasses is probably a little bit too strong. Sometimes I start patients at a 0.5 or 0.75, so it doesn't blur their visual world, so it's a little bit generous for this distance, but it also doesn't blur their vision across the room as much. So less is more. It's a concept that's true in eye care. When you're in your 50s, you're going to need a somewhere between a 150 and a 2 strength. Okay. And when
Okay.
you're in your mid to late 50s, it's going to go up to 2 to 250 and maybe 3 in rare cases. So that's how the focusing aspect's going to change. If you get a cataract, that can change your prescription quite a bit, and that
Okay.
can make somebody nearsighted again. And
Okay.
they'll, they call it second sight is the old term, because everybody, well, gee, I had great eyes, but then I had to wear reading glasses and reading glasses and reading glasses and stronger reading glasses. But then when they get nearsighted, now I can see to read without reading glasses again, but I can't see far away again. That's what a cataract will do.
Okay. That's fascinating. I love that you're providing some of the cues for people based on their age, kind of what type of reading glasses to look for. So I know I was talking to you earlier about I have a client who has the multifocal lenses. So I'm curious your thoughts, because he uses the computer screen, and so with the multifocal lenses, he has to tilt his head up a lot, which hurts his neck, which is a big issue. And he didn't think about the reading glasses part. And so I asked him, I said, do you have reading glasses? And he's like, oh, I didn't even think about it. So I'm just curious, kind of, can you talk about the multifocal lenses a little bit?
Yes, that's a great question. So 20, 25 years ago, we were blessed with the progressive lens, the no
Yeah.
line bifocal. So you could have the old line bifocal where beneath the line it's in focus for here, and then above the line it's in focus for distance. And we would always tell patients the lined bifocal is no good for computer, because not only is the power down here and you have to do this to get into it, okay, it's too
Yeah.
strong for the computer and you got to get way close. So here comes the progressive lens. Awesome, right? Well, it does have its limitations and pitfalls as well. So in a progressive lens, the power progresses or gets stronger from the distance power to the maximum power gradually as you go down. The power that is in focus for the computer screen about 2 or 3 feet away is generally about 15 degrees below the straight ahead. So the most common problem I see is that a patient's screen is too high and they're too low. So if you are using a regular progressive lens with the computer, you want to strive to get your eye level at the top of the monitor, if not a couple inches higher. So you want to be 0 to 3 inches at or above the top of the monitor. Then you can gaze downward with your eyes through the correct part of the lens and see the screen and not have to do this.
That's awesome.
Doing this might also be an indication that that patient's prescription has changed in some other way too. Okay. For the last 5 or 10 years and getting better over time, we've had better versions of progressive lenses that at first they were called computer lenses. I don't like the term computer lenses because not everybody that does near work looks at a computer all day and do other things. I like to call them office lenses. So if you can imagine a progressive lens, you've got, distance, intermediate, near. In a progressive lens, the part of that lens that's in focus for the computer screen, it doesn't take up a whole lot of the real estate of that lens. It's a small area. So patients still have to turn their head a little bit. So an office lens makes that intermediate focal area a lot bigger, and it pushes it up higher, and it's therefore more forgiving for those patients that screen is a little bit too high.
Okay.
That lens is no more an all-purpose lens than their progressive lenses, because they wouldn't like driving down the road with it because the distance zone is compromised. They're going to have to go like this to see the distance. I just tell patients, a lot of times patients come in, I need a new pair of glasses. Well, no, you don't. Your prescription didn't change, but you need an office lens. I don't want 2 pair of glasses. Well, put this one here at your desk. When you get to work, put it on. When you go home from work, put the other ones on. Okay. And they're happy as a clam. And I have had patients tell me that their neck and their shoulders have never felt better.
Yeah.
Not the only way to do it. You could do a single vision lens. You can make a lens with the same power in the whole lens for the computer screen. And that way, the amount of real estate that power takes up is maximized. The pitfall of doing that is if that patient needs a stronger power for a book distance. Okay, I don't know, I'm balancing my checkbook and I've got QuickBooks here and I'm entering checks here. Those are 2 different distances. The single focus lens may not be ideal for that patient.
Yeah, then they're constantly moving their head if they or the book or whatever. So that's interesting. And then there's also the whole factor with sunglasses too. Like you could have sunglasses that have a lens component in it too, right?
Yeah, prescription sunglasses.
Okay. Okay. So sounds like there's a lot of options out there that people can use to help their vision, but also keep in mind not to be a detriment to their body.
Right. And the awesome
Yeah,
thing is that technology, being that it always moves forward, things only get
yeah,
better over time.
absolutely. Completely, yes. Are there any other conditions that are common that we didn't touch on regarding eyes and eye care? Anything that come to mind?
You we covered a lot of bases, and racking my brain here.
Yeah.
Technology holds promise for the future in terms of telemedicine,
Hmm.
but there are limitations. And for example, when we had to shut down back in March, April from the pandemic, I did
Hmm.
one or two Zoom exams because the patient didn't want to come in, and that's fine.
Yeah.
There's only, this a cell phone picture or get real close to your camera.
Yeah.
The resolution and the magnification only does so well, right? It's like how
Yeah.
accurate do we want to be? And so I think over time we should be able to do better. I mean,
Hmm.
the other thing is, this whole online eye exam thing. I mean, how accurate do we really think we can be with an internet-based prescription determination? And then it says right on there, this is not an eye health examination. So why do they call it an exam anyway? And it's
Yeah.
one of my pet peeves. And if I can kind of go on a diatribe for a moment here,
Sure.
that I think an expectation is, people go to the eye doctor and they put the instrument in front of them with all the lenses, and is this lens clear, that lens clear, one, two, blah, blah, blah. That's in their mind, that's the exam, right? And there are certain components that make up an eye exam, and I jotted them down just so I wouldn't forget them, but I want to be very articulate about this because
Yeah.
this is what makes up an eye exam, okay?
Sure.
Personal and family eye and health history. Attention needs to be paid to that.
Okay.
Visual acuity and visual function determination as part of the prescription assessment. Okay. Neurological examination, the alignment of the eyes, pupils, focusing, the extent of motion. We're talking about cranial nerves here. 2, 3, 4, 5, and 6 are almost totally related to eyes and vision, and other cranial nerves have connections. Okay. A peripheral vision assessment, at least at a basic level, color vision, intraocular pressure, a microscopic evaluation of the front surface of the eyes and surrounding structures, the internal structures, the iris and the pupil and the lens, and then the evaluation of the retina and the vitreous through
Yeah.
dilated pupils, optic nerve, the macula, vessels, and the peripheral retina. And what does dilate mean? You've heard that term, right? Dilate means to make bigger. So if I'm looking in your eyes and I have a scope and I'm scanning around, what is happening? Your pupil is constricting, right? So that
Hmm.
limits how much. I mean, would you rather look through a pinhole, 1 to 2 millimeter pupil, or a 5 to 6 millimeter pupil that does not constrict? So we put drops in the eyes that dilate the eyes. And it's
Hmm.
not like we need 8 millimeter pupils, although that's kind of nice to look through, but we need a good, somewhere 5, 6, 7 that are fixed, and then we can look all around. And
Yeah.
dilation of the eyes as part of an examination is the standard of care, always has been. No technology can supplant that. Okay, so
Yeah.
those are the items that make up an eye exam, not just the lens part of it.
Yeah. And so people that are doing just a virtual visit, telehealth, they're missing out on so much of that.
Hmm.
And we know there's ways you can protect yourself to still go in person to see someone and it's still safe and you can get your full eye exam. It's,
Yeah, I mean, a doctor's office is probably one of the safest places you can be,
yeah.
because
Yeah.
doctors have made great amounts of changes in their practice protocol, how many people can occupy their space at one time. I did a little bit of a math problem here a few months ago,
Hmm.
so I would have this on the tip of my tongue if the patient asks. So we talk about this, and we need to respect this 6-foot social distance. So if we respect that 6 feet social distance, so a circle with a 6-foot radius has about 112, 113 square feet of area.
Hmm.
That's how many square feet of area. So and we're fortunate here in my office because like when I first moved into my office and did the build out, we had more space than what we needed. So it was kind of like costing me more than, but now we can spread out and we never were tripping on each other. So if I have every single person working in my office and we have 5 patients in the office spread out, a couple up front over here, a couple in exam rooms, we have 385 square feet per patient.
Nice.
So we've tripled the area for the social distance. And I've made some indoor air quality modifications to the office too. But generally speaking, doctors' offices are one of the safest places to be.
Yeah, yeah. And you can't make up a true in-person exam when it comes to your eyes. I mean, everything you described, I wouldn't want to risk having some type of condition that is going to be a detriment to my vision just because I couldn't get in to see you and have you do that thorough exam.
Right,
It's
right.
important.
Indeed, I can't examine you from 6 feet away, but with masks and breath shields and the air purifiers and whatnot, the risk is really, really minimized.
Yeah. And it's not like you're there for hours on end. It's, it's an exam. You get close, you have the protection, you can move apart, discuss what you see. You can see that it could be a very safe experience.
Correct.
So if you're just thinking just like your top tips on eye health, what are the few things that you might recommend, 1 or 2 or whatever?
Sure. So we talked about sunglasses. They're very, very important. Protect your eyes from the sun. Eat a healthy diet. Okay. So get enough sleep. The connection isn't like a 1-to-1, but it's good for your overall health.
Yes.
See your eye doctor periodically, whatever he or she recommends, 1 year or 2 years. And those are my top tips. Take a break from the screen. Okay. And I see a lot. We talked about the 20-20-20 rule, but also with kids and devices, a lot of times kids will say, "Oh, I have trouble focusing." Well, how many hours a day are you looking at your cell phone? Well, the true answer is like 5 hours a day. That's too much.
Yeah.
So limit the device use. Go outside, go for a walk. Do something. And those are, I guess, my top tips.
That's great. Can you go through the 20-20-20 rule just one more time for everyone?
Sure. It talks about every 20 minutes, so 3 times an hour, you want to look at something that's at least 20 feet away, so across a room, out a window, for 20 seconds. And if it takes a few seconds for that object or that text you're looking at to clear up, that's how long it takes for your eyes to relax or change their focus from something close to you like a screen or a book to the distant object. So you should do that 3 times an hour and you will become less fatigued, hopefully.
Yeah, wonderful. Thank you. And so how can people reach you? What's the best way for them to get more information about you or find you?
Sure. If somebody wants to send me an email, the easiest one is lee@drleenewton.com, lee@drleenewton.com.
Okay,
If
wonderful.
they'd like to request, I'm working on, I put together kind of like a top 10 list, top 10 or 12 tips. There might be 12 or 13. I'm actually going to make it into an ebook. I'm just not done with it yet. So if anybody wants that ebook when I get it done in another week or 2, send me an email. I'll be happy to send it on to them.
Oh, thank you. That's great. Really appreciate that. So thank you so much for your time today. You gave us tons of great information about our eyes and just the different conditions we hear about all the time. So really appreciate your time.
My pleasure, Amy, and I appreciate the opportunity.
Thank you. And thank you all for watching today. Thanks for joining us on the Weekend Wellness Hour show. Have a great rest of your weekend. We will see you next week, next Saturday. Have a great day. Bye, guys.